Good morning, fellow chiropractors. Welcome to CASA Congress 2018. Millennial Chiropractic, an integrative approach to neuromuscular skeletal healthcare, promoting evidence-based chiropractic. That's the theme for CASA Congress this year. I'm very excited. We've got a wonderful lineup of speakers. A lot of people have traveled a long way. We've also have Dr. Chuck, who's on his way after this. He's flying out to New Zealand, so he spared us time this morning. We're very appreciative. We are going to have a lot of fun this morning and for the rest of the weekend. Just please check out the schedule, and we do need to run on time here. We are broadcasting to all those people out there in cyberspace, as Dr. Malinda says. Welcome. I hope your feed is good. If you do get cut off, everything's being recorded. We did give you Marnus, our technician's cell phone number that you can WhatsApp if there's any particular problem. All right, without any further ado, we'd really like to thank Nedbank for a mammoth effort. This has been a year of negotiation with Nedbank, and they've really come to the party. I am so impressed with their service and their help. Sol Zimba, Sadiqa Rayem, who started the process and unfortunately was in a car accident, broke her leg, and Sol Zimba stepped up to the plate, and his whole team, all the boardroom meetings on a regular basis, discussing who's doing what. I'm very impressed, and I really think this is the start of a fantastic relationship with Nedbank, and I want you guys to all get involved with Nedbank too. All right, so this morning, just for a brief on what Nedbank's got to offer us, we're very honored to have Grace Governor. She's the head of New Business Development and Sales Support. Grace Governor, ladies and gentlemen, Grace Governor.
Yeah, thank you. Perfect. So good morning, everybody. It's lovely to see as many of you at 8 o'clock in Sandton, and especially thought the weather would be warmer today, but clearly not. But it is warmer from what I heard this morning from Cape Town, so that's really incredible. So welcome to Cakic and to Nedbank, and I hope you enjoy our facilities. It's really great to have you here, and I have this opportunity to share our value proposition from a relationship banking perspective today, and in specific, the medical professional with regards to our offering. So really, thank you for your time. And to those of you who bank with Nedbank, thank you for your loyalty and your commitment, because we definitely can't do what we do without you. And for those of you who don't, I'm hoping after this session, very brief session, but I'm hoping you'll take the time to chat to our wonderful ladies and gentlemen here, Wayne. It's our medical professional team, and it's dedicated to the medical professional fraternity. They'll be outside, and you'll be able to talk to them in your breaks. So I'll give you the high level today. But obviously, for more detail, please, we'd encourage you to chat to them. We'd really like you to become part of the Nedbank family, and especially relationship banking. So thank you again for being here this morning. So without further ado, I want to take you through the high-level medical professional offering that we offer to clients such as yourself. We understand that your business can be complicated and that there are solutions required to meet the different needs that you may have for both yourselves and your practice. So from a relationship banking perspective, just to give you a quick overview, we serve various segments. Just a high level, we serve our small business segment, community, we serve professional banking, and we also recently serve our non-resident and embassy banking. But part of the professional banking offering that we have and the CVP we offer extends to our medical professional fraternity because of the kind of community that you serve and considering the different nuances that come with that community you serve. So we offer personal relationship banking with flexible benefits. We offer solutions and we offer products and services that are tailored for yourself and for your practices. We have a dedicated relationship banking team, which I've just mentioned, and they understand the medical industry and have the expertise within that particular industry. Your relationship banker is backed by a group of specialists from transactional banking to risk and specialists that come up with solutions to help solve for the industry that you serve, and therefore, the complexities that actually comes with as well. Now, I mentioned to you before that we serve, often make an offering to you from a personal capacity, including a business capacity, and from a personal capacity, professional banking offers and includes platinum status with local benefits from travel, including rewards and benefits, including international benefits for the very small amount of 317 Rand and 76 and a bundle offering. And we make sure that you have, with that comes your dedicated relationship banker, including other services, and a 24-hour contact center is there to support you as well. We also offer the same value proposition to what we call young professionals starting out in their careers under the age of 30 with a medical degree. We offer the entire value proposition for the value of 158 Rand and 38 per month. Members of the family are automatically included. So if you are a relationship banking customer, your family is also included in the value proposition, and the ladies here and the entire relationship banking fraternity will be able to support you in your efforts, taking care of your family, you and your practice. Members of your family as well will enjoy lifestyle and reward benefits, including travel insurance and bookings using your platinum credit card. We've recently also introduced, and speak to our ladies if you'd like, if you are traveling, we've recently introduced our Visa signature cards that offer you travel and international lounge visits, including some of your family members. So please take that opportunity to chat to them about it. Free airport lounge, as I've said, international lounges, 24/7 banking experiences, including our greenback rewards. Now, many a times, you may or may not heard of it, but you can also accumulate those greenback rewards and cash them, should you please, and spend on those wonderful things that you probably desire. For your practices also, so we see things differently from an individual perspective, and we see it from a business perspective. And we understand as a practice, you have different needs that you need to cater for within your industry. We offer vehicle finance and asset financing, specifically to medical equipment. We offer you business transactional banking, which includes the bundle offering and the pay-as-you-use offering. So you have different transactional offerings that will cater for your needs. We offer hassle-free medical aid switching and a point-of-sale device that allows you to exclusive rates, and if you look in the little goodie bags, I'm hoping that you've received already. There's a little bit more detail with regards to that, especially to our medical professionals. We offer short-term lending facilities, overdraft facilities, including gap access, which you may not have heard of or seen of, but I'd like to spend a little bit more on that just after this, and some commercial property finance included, investment and insurance support, and we have an entire financial planning community within Nedbank that will support you in your effort to try and accumulate wealth over a given period of time, and also value-added services that save time and money in running your practice. Now, with that, I'd like to maybe just spend a little bit more time on what we call gap access. Now, we understand access to funding is important. We also understand that there are different solutions, and sometimes you need that type of cash to actually start to either renovate businesses or buy specific medical equipment, and we've come up with this very innovative solution that allows you to get a cash advance for your practice based on historic POS transactions or volumes and data. Ideally used to fund operational expenditures such as as I've said, office renovations or equipment. The pricing structure is very transparent. The repayments are matched to your POS cash flow, which means it actually deducts a payment daily from your cash flow from your POS devices, which allows you to pay this off sooner, not to mention if your cash flow increases over that period of time, you could pay it off much faster. So we really encourage you to look at these solutions when you talk to Nedbank. Our relationship bankers are fully equipped to provide you with that advice, and we'd really like you to take the time and chat to them with regards to the different solutions that we offer. Now, before I close today, banking's never easy. And I know when people talk about banking, there's always, there's so many things out there for you to try and consume and understand. But from a Nedbank perspective, we try our level best to make banking simple, hassle-free, and with your dedicated relationship bankers, you have one point of contact. And considering the industry that you're in, I'm sure you don't have the time to run around to try and get your banking done. You have this point of contact. We've recently also introduced many digital functions like our Money app that's been launched into the industry. We'd encourage you, if you're Nedbankers from an individual perspective, please Download the app if you haven't. It is really awesome. I mean, I use it personally. I literally am able to do my banking on the run, and I'm sure you would like to as well. With that, I would like to thank you for your time this morning, and I wish you well, and I wish you have a wonderful time over the next couple of days, including enjoying the facilities of Nedbank. Thank you.
Thank you very much, Grace Govender. Nedbank are wonderful, and I'm very appreciative of your good work. If you can just give me a second, yeah. All right, I welcome our next speaker. It's wonderful to have Dr. Chuck. His proper name is Josip Cakic. Have I pronounced it correctly? Close enough. Okay. Dr. Chuck, excuse me a sec. Dr. Chuck was born in Zagreb, Croatia. Currently, he lives with his family in Johannesburg, South Africa. He achieved his medical qualification at the School of Medicine at the University of Zagreb in 1989. Following his internship and registration, he immigrated to South Africa in 1991, where he started as an intern at the then J.G. Strydom and Wits University hospitals. After his internship, he continued his education as part of surgical rotation at the Department of Surgery and obtained an orthopedic registrar appointment in 1995. In 1998, he graduated from Wits University as a fellow in the College of Surgeons in Orthopedics. Dr. Chuck went on to complete his PhD in orthopedic surgery in 2009. He treated many sports-oriented patients, and having a special interest in the hip joint, he started developing hip arthroscopy. In South Africa, in the last 10 years, hip arthroscopy has become a recognized orthopedic procedure. Dr. Chuck has established a training program for other orthopedic surgeons. Currently, he serves as the president of the International Hip Preservation Society. He is a founding member and past president of the South African Society for Hip Arthroscopy and is an international member of the American Academy of Orthopedic Surgeons. In 2006, he discovered anterior minimal invasive hip surgery. Dr. Chuck has established the AMIS procedure as his main surgical approach for total hip replacement and has become a reference surgeon for Medacta International in South Africa. Additionally, Dr. Chuck serves as a member of the editorial board for the Journal of Hip Preservation Surgery, as well as the review board for the American Journal of Sports Medicine. Ladies and gentlemen, please welcome Dr. Chuck.
I hope this microphone is going to be enough. I'm going to switch it on off. Thank you very much for having me here. Honored to be here. I hope you're going to enjoy 162 slides in the next hour and a half. I will try to make a break. I've tried to put my talk into the 3 sections so that we can stop, we can have a little break. You can ask the questions. Otherwise, it's going to be just too long. So, I'm working in South Africa, and I'm working in Johannesburg. This is my home. And I started something simply because I believe that preservation is the way to go. So, hip arthroscopy is something that I've always been intrigued, being an arthroplasty surgeon, is how to actually try to preserve the joint, just chuck it out and throw it in the dustbin. And that's how I came across hip arthroscopy. And interestingly, there was a few places in the world that had the same thinking, and we didn't even know each other. But the way how the brain thinks, it's on different planet parts, it's actually unite us into the interesting concept. So it's in a human curiosity to put eye and to look into any possible orifice. And hip was the first joint that actually scope was put it in. Not the shoulder, not the knee, the hip. And that happened a long time ago in 1931. Following that, in all the places in Japan, they start actually using it in kids in the presence of tuberculosis, because that was the main disease in that era. And then was going on. And for me, and for the modern technology, Glick and Tom Bird designed a future by designing the process that can be simple and can be usable and reusable. Following that, it just goes on and on. And then basically with the beginning of 21st century, we start looking into what we see and how we can use that knowledge clinically. And Dr. McCarthy from Boston, Harvard, he actually shows and presented that 73% of the labrum test directly correlates with arthritis. Following that, the thinking goes further, and Professor Gantz designed way of thinking rather than a concept of FAI is what is happening in alignment of the joint, and we're going to see that abbreviation often during this talk. So the first time they met together in 2004 in Cambridge, and then in 2008 we met together on a hip meeting in Paris, and during a nice little pub lunch we decided to put everything together, and that was the beginning of International Hip Arthroscopy Society. Now we have us out of 12 grown down to the 630 international members all around the world. We have publications of numerous books, and recently also the book of hip restoration, which was original book from the Isha members. So every member was having a chance to put input into that book based on their evidence and their experiences. 2011, we started Hip Arthroscopy Society in South Africa, and the same pattern happened in Australia, happened in Austria. And then in 2017, you will see how the brain was changing from arthroscopy as a technique into actually talking about technique of preservation, which involves many other tools, if you will, than hip arthroscopy. So why hip arthroscopy? Eventually, we're thinking about two categories of problems. And the one is basically you have something in a joint, is that sepsis or loose body or something, and you want to take it out. However, there is another group that is actually much more important, that what we don't see. So we try to find a way how to improve the physical life of the person with the problems that were before modern technology of diagnosing be completely unknown. So why do we care? This is a year difference picture left to right on a 22-year-old person. And you can see here, we're going to talk about that condition. And I explain to my patients very simple. If you're having a car, you can have a Ferrari, and if your tire is out of alignment, that tire is not going to last 50,000 miles. It's going to last 10,000 miles or 5,000 miles. So there is a much more into it than just biology. There's lots of mechanical things that we have to look into, and we'll come to that. So what we're trying to achieve, we're trying to actually bring that curve above the threshold line. And this is what is happening, what was happening, or it's happening in 20th century. And we try to move that in the 21st century, that we can diagnose, we can in a way prevent it, that actually changing that curve above the threshold of arthritis. And future is going to help, especially in involving preservation, and then adding to it a modern biologic techniques or some other things which future is going to bring to. But at the moment, we managed to pull that curve about 20% above the threshold. We know the normal anatomy. Femoral head, acetabulum, horseshoe type of cartilage and acetabulum surrounded with something which is called a labrum. Basically a seal, a gasket. I explain to my patients, imagine putting your notch in your mouth. Your lip, which is Latin name labrum, is going to seal that notch. That's what it's all about. So what is the function of that labrum? It basically is extension of the bony part of the skeleton of acetabulum for 1/3 of the volume and more or less 1/4 of the surface. And also has a suction effect. It's a negative pressure in the joint. You actually, if you're working on a cadaver and you have a femoral head inside of acetabulum, you can actually lift it up. It's like a plunger. And if you pull it, you're going to have that suction feeling and sound. The labrum is doing that suction effect, and that way the nature protects the chondral surface. So we have a plenty of diagnosis, differential diagnosis, what's happening with the hip and with the pelvis. We mustn't look narrow-minded through the keyhole. We have to look out of the box, further out into the whole pelvis. So what we're talking about? We're talking about that famous FAI. I'm purposely not saying what it means. You will see just now. We're talking about laxity, which is a purely muscular problem. We're talking about traumatic, dysplastic conditions, degenerative conditions, impactions either related to the muscle structure or traumatic lateral impaction, subluxation, subluxation dislocation, as well as vascular problems like avascular necrosis. So this is all related to the labrum and chondral surface, but there is more than that. We can have problems related to the inflammatory conditions, psoriatic arthritis, rheumatoid arthritis, Writer's disease, and so on. Again, in combination with the capsule. So all of those differential diagnoses that interacting one to another. Then we can have extra-articular problems, which presents as a hip pain. Is that a gluteus complex, or is that a snapping hip, which can be, or coxa saltans, which be internal or external? Is it related to trochanter? You'll come across something GTPS. This is a relatively new form of saying greater trochanter pain syndrome. Everybody talks about bursitis. It's not. Could be many conditions that are related to the greater trochanter. And that's why we're using that form of greater trochanter pain syndrome. But find out in a syndrome what is the cause. Then we're talking a psoas, biggest and strongest muscle in the body, as a flexor, and bursitis of it, or tendinopathies. Then we go back. We're going to the posterior compartment. Is it piriformis? Is it sacroiliac joint? Is it related to the tendinitis of any of the muscles and tendons related to the pelvis? Then we go a little bit higher, something called the subspinal impingement. Is it related to the anatomy of the pelvis? And then we go further out into the soft tissue of abdomen, so-called sports hernias. Again, we can have synovial problems deeper in the joint, and we can have a tumor, infection, and metabolic condition. It's just to see how complex it can be and how much we have to look out of the box, not just say, oh, this is it. There's much more into it. This kind of a diagnostic layer, we'll come across that later on again, that is show us how many things in different layers around the pelvis can be involved into the complex problem. But what actually makes the great surgeon is actually to make a decision when not to operate. That's my opinion. So how I can tell you only in my opinion. How do I decide yes or no for surgery? Everything starts with a history, with anamnesis, as Latin world says. To find a feel, in an interview with the patient, what is going on. Following that comes a very small percentage of additional information for the clinical examination, which is essential, but you already have a gut feeling what is happening by talking to the patient. And then confirmation of all of that is through the additional tests. So the history is very important. Find out how much of that is what is happening, how long, and so on and so forth. To understand what was happening, what event actually caused the trouble, why the patient came to see us. Is it specific traumatic episode? In which way? Or it's spontaneous, chronic, and so on and so forth. How to figure out, with the questions, you can already figure out if it's related to the intra-articular or extra-articular problem. And this is what the point is, to find a pinpointed where the problem origin is. Specifically for the hip, there's certain things that are going to make a condition worse. Like, for example, walking flat in the one direction is going to be perfectly fine, but as soon as it's involved the pivoting, movements laterally or uphill, downhill, start getting worse. Same with the position. Sitting position is getting worse than standing up or crossing the leg in a adduction. So there's a certain things that you can find out only if you ask specific questions. And then we're coming to the physical examination. Obviously starts from the standing, supine, lateral, prone, and then we do provocative tests. So the C sign, Tom Bird designed a long time ago, and it's validated test which is called the C sign. So essentially you're trying to hold the pelvis, as you can see on a picture, front and back. And if it's a nice little ballerina, it's easy. If it's a big rugby player, what I do, I stand behind the patient, control the pelvis with my side of my pelvis, and I press. And the patient tells me if it feels difference between pressure on the capsule. Basically what you're trying to do, if you have a knee problem, it's going to be swollen. You can see it, it's there. Same with the elbow, same with the ankle. Hip is deep. You can't see the difference, but you want to try to irritate it, and that's the function of the C sign. Standing weight-bearing rotation test. This is what I started in 2007. Basically, you're trying to irritate by moving the ball inside of the socket on a one-leg standing internal-external rotation. Then we're doing in a supine position the log rolling test, which is going to give us an idea about what's happening in a joint where there's no pressure in it. We have a classical Thomas test. I hope we all know what that means. And then we have a specific test for the labrum, which is called the Faber and Fader test. In other words, we're doing a flexion internal rotation, and we're doing a flexion external rotation with adduction or abduction, respectively. So we're trying to grind a femoral head inside of its acetabulum, and obviously at 1/3 of that surface is a labrum. If you come to the point the labrum is damaged, it's going to give you a signal. And then we're doing something which is called this resisted leg raising test, because you're putting a fulcrum onto the joint. And then by elevating the femoral head inside of the acetabulum under the resistance is going to cause certain symptoms. So those are very specific intra-articular condition tests. Telescoping. What I do, I put a patient on a table, stabilize one leg, and pull on another. And you will be surprised how many, especially ladies, you will be able to actually distract the femoral head out of the joint. And they get very much apprehensive about it. Is that hypermobility? Is that ligamentum teres injury? Is it a capsular injury? We don't know, but we have a fact that that patient has a hypermobile joint. And then it goes further to find out what is the cause of it. This is also one of the tests that my friend and colleague that I'm going to be with next week from Melbourne, John O'Donnell, designed and validated. When we're trying to see how ligamentum teres is going to respond to the testing. So what we do in a halfway, about 45 degrees flexion, we're doing an internal external rotation. Now the capsule and the ligamentum teres is almost like a half twisted towel. So when you're doing an external rotation, you actually undoing the towel. And if you're doing internal rotation, you're tightening it. So this is what's going to happen. As you can see, in internal rotation, which means the foot goes out, the patient is having a face change. Just watch her face. And this is the reason, because you're twisting that damaged ligamentum teres. And it's a very, very interesting test, and it's very, very helpful. Coming back to the telescoping and coming back to the main thing of hypermobility, there is a certain things that we can see. First of all, coming from South Africa, Baton long time ago designed a Baton mobility score, which I think everybody should use. And then we can just see, just watch the patient, watch how they walk, watch how they're having a relaxed legs on the table and see. And you can see the dial test. Just by pure lying on a bed, you can see the difference of external rotation of the foot, which is otherwise controlled by the capsular or soft tissue structures. Further out of the box, groin pain is not a single entity, but part of the syndrome of pelvic instability. It's going to become a little bit more clearer later on. So in essence, a colleague of mine said a long time ago that failure to recognize and address intra-articular hip pathology in addition to treat compensatory mechanisms can result in a failure. What does it mean is that you can have double-barrel symptoms, but trick is to find what is cause. What is the chicken, what is the egg? And in many times the pelvic presentation is actually a result of something else. So what are we talking about? And you're going to see this slide a few times. We're talking about a Bermuda Triangle, especially in a male gender, because we're supposed to be a stronger gender, but we have a paradoxical defect. Our testicle has to drop out. So we have a hole in the abdominal wall, and that is the weakest spot between the muscular structure of the abdominal wall and pelvis. And that's the point where, in a certain conditions, we can cause the pain. And that's what we're calling sports hernia, which you will see later on. It's gone through the ages of changing the names and trying to find how we're going to call this condition. But essentially, what do we see? Birmingham described it that if you're having, obviously this is exaggeration, but if you're having a micromotion in the hip, you're going to have a forces going through the pelvis in different directions. And if you do that, you're going to overload something else. Is that going to be athletic pubalgia? Is that going to be SIJ? Is that going to be internal, external muscle of the anterior wall of the abdomen? Irrelevant. You're going to have places where the force is going to find a way to get out. Same electricity finds the way to go to the least point of resistance. So this is a very interesting concept that I believe strongly into it, and it gets proven many times, as you will see later. But then we're having another thing. Now we have to see what is anatomical and what is a postural. If I have a problem in the hip, I'm going to automatically go into the retroversion. I'm going to drop my hip because flexion releases the pain in the hip. So we need to see how much of that is related to the posture and how much is related to weaknesses and problems of somewhere else. Then we need to palpate. We need to see where the pain can come through. And there is so many points that can be seen of cause of the pain, and then we start putting it together. Then we do the provocative test. Now we can see what is happening in active or active-assisted examinations. And we, again, involving stability of the pelvis with no stability of the pelvis, as you can see on the lower pictures, when you stabilize it and you're not stabilizing it, and so on and so forth. Then we're going into the prone, and we're looking into the posterior compartment, looking into the hamstrings, looking into anything else which is connected to the pelvis, and see what's going on. We're examining the hip again, and then we're examining also the power, which is also a very important thing, like a squeeze test of adductors that you can see. But you want to record it. So you can use the machines to record your results. And from Australia coming interesting finding that if the squeeze test is less than 100 millimeter of mercury, it's weak adductors. So we do using our dynamometers to measure actually how much weakness exists. So you can compare it with the future, and you can see how much of your rehabilitation or your surgery or whatever you're using is helping out. And then we go to the isokinetic test using a Biodex machines and recording all the problems, following with a dynamic testing of instability in motion. So most of my patients are having those tests done at about 3 to 4 months after the surgery. We're measuring instability between the pelvis and the knees, as well as we measure the instability and ratio between quads and hamstrings versus the stability of the pelvis. And all of those tests, especially in high-performance people, not necessarily professionals, gives an idea how fast we can push them into the training. We all spoke now and thinking about the front. What about the back? Pelvis is 3D structure. So we have a space between the ischium and the femur. And that is what you call an iffy space. Something iffy about it. And what it basically is called ischiofemoral impingement. I'm 100% sure that 15, 20 years ago, majority of the pain that was called the piriformis syndrome was actually ischiofemoral impingement. The only reason why we actually discovered it, because we could start doing certain modern tests like MRI. So we can measure it, the distance between the lesser trochanter and ischium and correlates that distance with the symptoms. Now you have the quadratus femoris, you have the sciatic nerve, you have the hamstring tendon, you have the vessels, and all of that in a 13 millimeter space. So if that space gets narrowed, one's going to have a problem. But because you have so many structures, you can have so many differential diagnoses. So you have to figure out what's going on. And that's why we're talking about problems of the hamstrings as well, problem of the quadratus femoris edema, possible neurological things related to the sciatic nerve, and so on and so forth. And there are specific tests that we try to isolate those problems. And thanks to a friend of mine from Texas, Hal Martin, and he is a guru in a posterior compartment, we designed, or he designed, a test that we can actually see and isolate one problem from the other. As you can see, the test that can be done in supine, prone, decubitus position, or sitting. And there is different ways how it can be done. For example, hamstrings, conjoint tendon, there's 3 tendons, and you want to isolate one from the other, and you do that by doing a test at 30 and 90 degrees, and you can find a difference which one is actually in problem. And same with a ischial-femoral impingement in hyperextension. Also can be done dynamically when you ask the patient to hyperextend, and it's going to tell you that the pain is there. But often they say, no, it's not, but it was yesterday. So we're coming back to the history, because if you ask that patient, can you sit more than 20 minutes? Yeah, I can, but I can shuffle. I can't, no. And then you ask them, what's happening when you go on an hour trip? And they say, yeah, it becomes uncomfortable sitting in a car. And normal person is not going to come to the doctor and say, listen, you know what, I can't sit in a car, I can't drive more than 45 minutes. You have to dig out those questions. So then we're coming to the famous piriformis. Obviously, there is existing piriformis syndrome, and it's related to anatomy, as we will see now. You can do it dynamically or you can do it passively. And all of that basically needs to be assessed and recorded. So what we designed in 2012, from 26 onwards, we designed a system of staging when we're using a test preoperatively and postoperatively, pre-rehabilitation, post-rehabilitation, to have a coding system, how we can measure it successful functional assessment, and we can see the progress of it. Break number 1. Any questions?
Sorry, just hold on a sec.
I think there are runarounds with a microphone somewhere. Yeah, it's coming.
Many thanks for a great presentation so far. The IFI syndrome, is it mostly a structural or a functional phenomenon? And in other words, is it sort of genetically determined insofar as bone structure is concerned? Or is it functional in terms of, for example, hypertonicity of muscles, things of that nature?
I think it's a combination of all of above. You will see just now in the second part that we can have anatomical variation of coxa valga, coxa vara, antetorsion, retrotorsion of the femur, and so on and so forth, which is going to anatomically narrow the space. That's one thing. Second thing is bringing a hip at risk, which means the problem can be functional. If you're a chess player, you're going to have less problems than if you're a hurdle runner. So it all depends if you're bringing the hip with anatomical variation at risk. So I can't answer you to your question. It's only one thing. It's combination of. And that also has to be discovered, and most of it coming from the history, because patient tells you what they want and what they expect from the hip, or pelvis for that matter. I hope that answers your question.
Thank you.
Thanks. Good morning. A 45-year-old cyclist who falls laterally onto the tar and has a telescoping of the femoral neck, has surgery, has had no rehabilitation. What are the chances of the labrum not being injured? No MRI was done.
If I know answer to that question, I will have an island in Caribbean and I will sit there and have...
Should it be investigated as a matter of course?
Absolutely.
Yes.
The first and foremost, the lateral impaction injuries are mainly injuries of chondral surface.
Yes.
That's what you do.
Yeah.
So that cartilage is damaged, period, in that split second. It's the same like I tell my patients, take an apple, throw it on the floor, pick it up, cut it in half, 2 days later you're going to have a brown spot. Looks perfect from outside, but there's a brown spot. And that never goes away. So that is going to give us symptoms later in life. So that's one story. Now, it's very difficult to find out how the cyclists fall. Trust me, they never just fall.
No.
That is a speed, there is a rotation, there is all other things that is involved. So is it possible that if it's a telescope, what you're saying positive, that means there was definitely some kind of a twisting involved.
Sorry, correction. It wasn't a telescoping on your test.
Yes.
The femoral neck was compressed.
Okay.
Yeah.
So it's highly unlikely if it's just a fall, that is going to be labrum damaged, but it's highly likely to have a chondral damage. Symptoms presentation is going to be very similar. The best way to do it is to do the MRI, because it's going to show you soft tissue, and we'll come to that just now in the second part, and it's going to show you also if you're having a bruise. Is it edema in a bone? The cancellous bone reacts. If I hit you in a shin, from outside is nothing. If I take MRI, you're going to have an increased signal in that area, and you can't do nothing about it except wait.
So there would be no intervention at this stage anyway?
Not necessarily.
Okay.
Many times people send a patient to me, says there's a hip problem, and we decided it was a stress fracture, that was something else. It's indifferential diagnosis. And as I said, decision-making process is when to decide not to operate.
Thank you.
2 minutes.
Good morning. I just want to collaborate on what he asked earlier about the IFI syndrome. How do you treat it if it's either structurally a genetic issue or if it's a biomechanical functional issue? Do you have to address it to reduce the pressure in that allotted space? What do you do?
Surgically, you need to expand the space. So you need to make that space bigger. And that space is between trochanter, lesser trochanter, and ischium. Now, problem is, I'm going to go in, I'm chop it off, fine. The problem is, lesser trochanter, attachment of psoas. Ischium, attachments of hamstrings. So you need to know what the person does. You need to assess the other structures, because if the attachment of the hamstrings is in any way impaired, you're going to go on that side, you're going to fix the problem of the space at the same time as tendinopathy. If it's not, then you're going to go on the lesser side because it's much easier surgery, and you're going to try to increase that space by doing a posterior lesser trochanter osteotomy, leaving anterior psoas intact. But sometimes you have to take it off that psoas, which means you're going to take 25% of the flexion function for the next 6 months to a year. So you can't do that into the hurdle runner, but you can do that to the chess player. So there's all those things that you're taking in on a clinical examination and a history that make a decision how you're going to treat it. But in essence, you're opening the space.
Okay.
15 seconds. Okay. May I continue? So we'll start this with a little movie. I wanted to confuse you a little bit more. So just watch. So is it a pelvis illusion or not? It's all about how do you looking into it and what do you see? And try to figure it out. And that's is important to understand that the picture is not good enough. It has to be a little bit more imagination into it and take all the points of view into consideration. Again, anatomy, very simple, but has the variations. You can have a coxa vara, you can have a coxa valga, you can have a neutral angle between femoral head neck junction as well as the shaft. Then you can have a coxa profunda, which is a deep joint. You can have a protrusio, which is even deeper. You can have a retroversion, which shows as a crossover sign. You can have an anteversion, which is a posterior wall sign. And then you can have a ischial spine, which means that the whole pelvis is tilted. So all of those are anatomical variation of the same thing. Finally, FAI, femoral acetabular impingement. You can have a bump on a door, you can have a bump on a frame. You can have a bump on a femoral head or on the socket. One way or another, the poor labrum in between, which is a seal, is going to get damaged. So when we're talking about femoral side, in other words, CAM, you can see from open surgery the pictures of how this alignment is damaged and that alignment is reconstructed. And if we see in animation, this is what happens. And that's what comes to the point what I said before. You have to bring hip at risk. If you don't do those motions, you're not going to have a problem. But what happens is, with that hunchback, with that cam, the labrum gets irritated, and with the repetition of all of those motions, it's going to break off. Now, all the nerves are there. If you damage your nail in periphery, you don't feel it. If you're damaging a nail bad, it's going to be damn sore. So you need to piss off the nerve to become aware of the problem. And that's why those patients are chronic. They go for a long time, and they're being classified as being a very, very stiff. No, they're not stiff. They just have a bad alignment. Then we're going to the pincer. That pincer, because in a process, that acetabulum edge is very low. It's going to leave the mark every time when the head go forward because of the X effect. So you can see that mark, and you can see how that labrum, because it gets pushed, I call it a parrot beak presentation. It gets folded inwards. It's a different mechanism with the same result. So then we're talking about those anatomical variations, and we can have two types of dysplasia. We can have a dysplasia that we know that everybody talks dysplasia about being a subluxing hip, which is on the right-hand side, and you have a different amount of undercovering the joint because mother gave a bad genes, so the hip is not developed. Or we can have a hip dysplasia that is too deep, coxa profunda, when essentially the joint, the femur, crossing the wall. The wall is pushed even further medially. And this is how this looks like. You can see those lines when those lines are crossing normally, and here it's beyond. Very subtle sign, but very important. Or you can have, on the other hand, you can have an overcoverage, and in dysplasia, look at how this is vertical or towards vertical compared to the other side. This is dysplasia. We measure certain angles, as you can see just now. And then we can have a very typical African syndrome, which is called Johannesburg syndrome, where the specifically black population, it's called Johannesburg because it was done in Wits, but it actually should be called the Zulu or Natal because it's related to specifically black population, young female genders, when they can develop extreme coxa profunda and end up being arthritis in a very early age. Now, as I said, illusion. We have to use the different views to see what we want to see, so we don't assume. And that's why we're doing a different picture. So here, you can see how that hip looks perfectly fine. Fairly normal X-ray. But when you twist it, you can see the hunchbacks. You see the cam. On the other hand, if we're looking that hip, it looks fairly normal to average eye. But when you try to twist it, you see there's absolutely no space. So this is example of cam, and this is example of pincer. So in order to see that on a 2D presentation, you need to have a proper X-ray. And there's a certain rules that radiography has to know. So we need to have a space about 1 inch between the coccyx and top of the symphysis, and obturator foramina has to be identical. So what does it mean? You're going to avoid rotational and tilting problems and exclude them. Only then you can do and take a pen and measure. What do we measure? We measure lateral edge angle, which should be around 30 degrees. We measure the tonus angle, and all of that is in horizontality of the what we're calling a teardrop. So then we're having a tonus angle or lateral social angle, and on the lateral views we can measure anterior edge angle, because your socket can be changed in all 3 directions. So you need to have idea about it. That is the cheapest way to do it. What does it mean anatomically? On here is a normal pelvis. So the pelvis sitting nicely, and we can see that socket inside of the pelvis is actually anteverted. On the other hand, on the other side, this socket is retroverted. So those 2 lines that you see, red and yellow, sits like that, and when you're having a retroversion, it's going to cross. And that's what we're calling a crossover sign. So it tells you that this, anatomically, that socket is badly put inside of the pelvis. We know from a long time ago from McCarthy that actually X-ray is a very poor indicative tool of what's happening inside of the joint. So we have to look for the telltale signs. We have to look for the hidden sign. For the normal eye, this is fairly normal hip. That cartilage is buggered. But how we could find out before putting a camera inside, am I doing a good or bad for that patient? So what are we looking for? We're looking for the telltale sign, as I said. This is just another example. Fairly normal, huge damage, 40 years of age. So what do we look? We look for the little signs. I don't know if you're going to be able to see it here, but there is a little calcification. That is a labrum. Put yourself on all 4s, and your shoulder and a hip becomes the same. So you can have a calcification in the rotator cuff, you can have a calcification in the shoulder, same as the hip. Calcium, in my mind, is just a telltale sign that something happened a long time ago and the body tried to heal it. And that is inside of the labrum. On the other hand, we can have a signs like this, which is pothole. That means that that pothole, synovial pit officially, is a result of some contact. Then we can have an ischial sign. You can see the ischial patineal line going there, which is telling us that that socket is twisted. And then what we look for some other things. We look subchondral changings, calcification, synovial pit, and calcification on the inferior side. So how does it look like? Calcifications, synovial pits. I didn't mark that calcification there. And synovial pit on the neck. And now, looks fairly okayish X-ray. And then you turn it. This is far from being a perfect circle. So, coming to that famous alpha angle. This is a measurement of the cam. But is it really all about alpha angle? Not really. First and foremost, it can be in different places. This is how it looks like when you actually having a picture on AP, but when you turn, it's normal. You can have it on a side, or you can have it anteriorly. So it's on a circle. It can be in China, and it can be in Europe. So you need to understand that that deformity can happen in any place around the femoral head and neck junction. Yes, we do measure it, and the book says it has to be below 50 degrees. But there's so many other things that you will see. Like, for example, torsion. So if I'm measuring the alpha angle, what about the femur? What I'm talking about is called the antetorsion, or torsion of the femur. Basically, it's a measurement of angle of the shaft neck angle versus condyle, femoral condyle. So how do we measure that? On a CT scan, you interimpose superior and distal part, the proximal distal part of the femur, and you measure the angle between. So what do we have? We can have a normal anteversion, which is about 12 degrees, 15 degrees plus minus 5. You can have excessive anteversion, and those are the people that try to walk intoeing, as the picture shows. Or you can have retroversion or retrotorsion, which gives you completely opposite duck walking. So what's happening? I have an alpha angle increased. I have a retroverted hip, acetabulum, and I'm having a torsion. So I'm having 3 different places on acetabulum that altogether is going to give me some answer. So if somebody has antetorsion and has anteversion, that's called the spastic hip. That hip is shallow. But if somebody has a retrotorsion and retroversion, it's going to have a deep hip. It's going to have a closed hip, and so on and so forth. So you have to take 3 different things, put it together, and take one angle away from the other angle and put it together, or take it away, and all of that. And then you say, fine, I'm done. No. Pelvic tilt. Head and neck angle. Iffy stuff. Subspinal impingement. And famous alpha angle. So there's so many different things that you have to think about it before you're actually making diagnosis. And you have to take all of that in consideration before you tell the patient, okay, I'm going to have a surgery or not. How do we help each other? Or how I help myself to see that. So we can use a 3D CT scan reconstructions that beautifully showing the calcifications and changings on the femoral head and neck junction, as we've seen it before. Then we can use an MRI arthrogram when we fill up the joint with a dye, and we can see where this labrum is separated from bone. At the same time, we can do the analysis of the chondral surface and see and tell the patient, listen, your hip is buggered. If whatever I do, I'm not going to help you. Because that cartilage is not attached to that bone. You can see that contrast went in between the cartilage and the bone. It's like having a water under the carpet. It's not normal. Then we can do extra stuff. Very good friend of mine, Gephardt in Vienna, they designed a traction inside of MRI. So you can analyze the chondral surface and the ligamentum teres even better. And then we can go and we can analyze it on a computer and tell the computer, okay, move my hip. So we can do what we're calling a collision study. So I'm taking a CT scan of the patient, I'm sending it to the smart people, patient pays for it, that comes back. So I can analyze it where actually impaction happens on that specific patient, that specific hip. So what does it mean? Patient comes back, and it shows me on result where the contact happened. And I can plan my surgery much more accurately based on that. By the way, that is a condition called a subspinal impingement, when you have calcifications above the joint, which involves the mechanic of the hip motion. On top of that, computer can tell me how much bone I have to remove to avoid any more skeletal collision, coming from white, which is a 0.5 millimeter, to dark blue, which is a 5 millimeters. And this is how it comes as a report as well, that I can see analysis on a clock spectrum, basically where the cam is happening, how much coverage of the femoral head I have, same with the socket, where and how much over coverage the patient has, and where on the clock presentation, and then combining that with the condyles to see other angles that we talked about it before. So this, the whole that algorithm that was about what to do and how to do which angles, computer does it for us. So we can have a better idea of what we're doing and how we're going to do it. Okay? Battery dead. Okay. Next break. Any questions?
Thank you. Insofar as this computer-generated image that you've just shown us now is concerned, how certain can you be that you've included all the relevant variables in terms of structure and movement that you can draw conclusions with a degree of certainty and reliability?
I don't know the answer to that question because this is involving the skeletal part of the musculoskeletal system. That's why the next generation of those dynamic testing is coming based on MRI. So that involves the soft tissue into whole equation because all of that is based purely on skeleton. So how certain I am still believe my gut. It gives me more information. What I'm telling to my patient, because they have to pay 100 euros for that. What I tell to my patient difference is 10 years ago, you were going for hiking having a map. Today, you're going on hiking having a GPS. And that's the difference by planning operation on an X-ray and planning operation based on a CT scan and dynamic testing. It definitely improves my accuracy. But does it improve my surgical technique? No.
Thank you.
I'm not sure how much you've had a look into, say, stem cell therapy to inject into the hip joint. If it's, depending on the level of damage, how much of that are you looking into at this stage? Say pre-surgery, see how much it improves before you actually go in and...
As far as I'm aware, stem cell treatment is illegal. There's 7 places in the world that is allowed to do the research. But treatment-wise, there's only one place that I know that is allowed to do the treatment, which is in Chile. Talking about orthopedics. I'm not talking about anything else. So that's the only place where we can actually treat people with the stem cells related to the chondral surface. What I mean by that we're taking your cartilage, we're using the stem cells that's going to grow the cartilage, and then in the second operation, you have inserted those cartilage and stem cells into your hip. The research on a stem cell is the future. There's no doubt about it. What we do here, what I do here, we're using a PRP. Platelets-rich plasma. Why? Because platelets, when you cut yourself, you have a scab. Now, something has to decide for that scab on your skin to turn into the scar that's going to imitate the skin, not the bowel. And that is the function of the growth factors. Now, the growth factors is like a lotto. You have 9 growth factors. Each of them has so many specimens in it. So if you could try to find a combination of all those 9, what is going to do in a body? It's a mess. So we're trying to figure out which one of those increasing inflammation, decreasing inflammation, helping the healing, not helping the healing. But at the moment, we're concentrating them. In a theory, you concentrate the growth factors, hence you're going to have an increased healing. It does work very well on a tendons, but inside of the joint on a chondral surface, we don't know. I personally didn't find any results of improvement.
That's with PRP?
PRP.
Okay.
That's why I'm more inclined to use a hyaluronic acid. as a lubricant in a joint, as a biological treatment. The future will show. I did some personal research on that comparatively. I didn't find any significant difference. And success rate was directly related to amount of damage. Okay?
Dr. Chuck, how would you say, how reliable are your orthopedic tests, and how often do they concur pre-3D scan, recon, MRI? What is your opinion on your orthopedic testing and the reliability of the tests that you've demonstrated to us?
I suppose that is answer is in experience. After so many times you're repeating certain tests, you start getting a sixth sense of what you're looking and how you're doing it. I know 90% of my answer before I even start doing examinations. So I don't, depending on those tests. And I'm not sending every patient on asking every patient to spend 100 euros for the test that goes to Holland and comes back and whatever. I'm using for those tests when I'm confused or when I have extremes of too much or too little. So when I need to be more careful, it sounds horrible, but more careful than average. So when I wanted to have a more information about what I need to do. It's an economical thing. You know, we're doing it now, Delphi studies all around the world, that we are trying to find answers to make it like a pathway, a global pathway of how to do the surgery. And one of the questions is related to collision study. And out of 600 members that answered back, you will be surprised how many people in the world says, but we don't even know what it is. We don't have access to that. So the point is, I do not depending on those tests. I depending on my clinical examination and plain X-ray. Everything else is addition to it. If that answers your question.
Hi. Can you comment on in-towing in toddlers?
I'm not a pediatric orthopedic surgeon, but what I can tell you from remembering my exam days, certain deformity involving the torsion and the valgus knees are normal and physiological up to the age of 8. All the toddlers are going to have a varus knee and internal or external retrotorsion, and they're going to turn into the antetorsion and the valgus knees. And they're going to straight up and land up femur to be about 7 degrees in angle between the femur, proximal and distal part of the femur. So I would be very careful assessing those things in development age. That's why that field is very much so specific. Because nature heals and nature changes. So we mustn't forget that. So that's why operations in the pediatrics are very rare. Only if it's really necessary, because you want to take potential of the growth in your advantage. One more question? No? You're not falling asleep yet, okay. So, now we decided we have patient, we had x-rays, we have everything, we're going to theater. How do I do that? Now, it's a ball and socket joint, and I need to sublux the joint. So I need to make a space between the femur and acetabulum. I tell all my patients that they are not going to be indecent in any moment of surgery because they're asleep. And their dignity is protected. And it's literally very kind of funny position, because it's like, I tell the patient, it's like being sitting on a horse and having a stirrups pulling down. I have to distract that femoral head out of the acetabulum for the certain amount of time and length. So this is how we position. I'm standing on the side. The C-arm comes in between the legs, and I have my screen opposite me. That's the basic, which I'm using for when I'm explaining to registrars how it works. So this is the system, how it looks like in theatre. So I have my leg in traction. I have my radiological presentation, whatever that I need to put it on a screen there. I have my 3 screens that I can combine different analysis if I want to do something. This is for my own protection from x-rays. And that's how it looks like. Once when it's prepared and done, it's covered, goes about 20 liters of water through that leg. So that's why we're collecting the water underneath, because arthroscopy is done under the, in a water environment. Those are the portals. That is a trochanter. Obviously that's anterior, posterior, foot is there, head is left. So that's anterolateral portal, posterolateral portal, anterior portal, and then additional portals if I need to poke around a little bit more. The whole idea is that I do not do damage on the way in. And the only thing what you want to actually to perforate is a capsule. Obviously you're stabbing a person, so there's going to be some muscle damage on penetration. And that's why we're using an x-ray, that I can see exactly where I am. We're putting a needle inside first. Following that needle, I can put the wire through the needle, remove the needle, wire stays, and then wire is a guide to my cannula. Just exchange of instruments in it to do the least possible damage. And all of that is done under the image intensifier. So I fry myself every day. And this is a kind of a diagram of what's going on. So you have 3 portals, one for the water, one for the viewing, one for the work. And you can exchange among 3 holes. And this is how it looks like in real life. So what do I see? This wire is going now through the anterior portal. That is in front. And then wire goes out, the cannula goes in, and I can see. So the first portal I'm doing under image. The other 2 I'm doing under vision. So I'm looking from the lateral portal, anterolateral portal, and I'm looking upwards. The camera is a 70 degrees, so it's like a periscope. If you turn it that way, you see up. If you turn that way, you see down. Now I turn it 90 degrees or 70 degrees, and I'm looking down. This is a 6 o'clock now. This is underneath there is a piriformis sciatic nerve butt. That's what it is. So through the capsule, I'm putting a needle on the. That is a labrum, which is attached to the chondral surface. That's the femoral head. And when I'm having that triangulation with all 3 cannulas, then I can play around and I can see what's going on. Then I exchange. Now I'm looking from the 12 o'clock down, so I see 3 o'clock and 6 o'clock. That makes sense? This is a deep part of the joint, because remember the joint is like a horseshoe cartilage, and in the middle we have a fovea where the ligamentum teres is. And that structure that's floating in the water, it's a ligamentum teres, which is not normal. That's the labrum. And I'm doing a 360 degrees turnaround to do the preoperative assessment before I continue with anything else. If I want to go to periphery, I'm using those other portals. I bend the leg, traction is released, so there's no more need to be ball out of the socket. And then I'm putting a needle there where you can see on a picture in the front of the hip. And then I put over the needle a wire, over the wire a cannula, and that's what I see. So this is now a view into the hip when the ball, femoral head, is inside of that acetabulum, and that's the labrum. And you can see the seal effect of the labrum. Now I want to turn and I want to look that way. So I'm looking there. So it's anteromedial towards groin. And this structure that you see here is called the medial synovial fold. So this is kind of a house flag. When you're there, you know that you're in the right spot, you know where your orientation is, and then you can start working on it. And that structure that you see there, that is called zona orbicularis. It's like an additional seal, like a collar around the neck, and it runs around here. So essentially, the hip joint has an intraarticular space, which is inside of the capsule, and that intracapsular space is separated in two compartments, which is separated by the zona orbicularis. And that's very important to understand because of how the fluid goes through the joint and how lubrication is happening and everything else. And this is my job. This is what I do. I do that all under image intensifier guidance. If somebody has a cam, I want to change it into concavity. I want to make a space. I want to file the door to fit into the frame. And that's what we do. In that process, we need to repair the labrum. And for that, we're using a very expensive little anchors. In order to do that, we need to stitch it together and allow the bleeding. And this is how that stitch looks like inside of hip. It can be a loop. Now, you see this. Okay, this is a femoral head. Down there is that center where the ligamentum is. So 12 o'clock is on top, 6 o'clock is at the bottom. That will be 3 o'clock. That's the left hip. And you can see how this cartilage is lifted up. So that's called a bubble formation. It's like putting a sticker on a windscreen that has an A underneath. That cartilage is not anymore nicely connected to the bone. And the reason for it is because when you have a labrum tear, you're going to open that space and the normal joint fluid is going to pass into it and it's going to start gradually lifting the cartilage. This is how I do. This is a loop of the stitch with a certain technique, and that's how it looks like. Just for your, this is 5 millimeter diameter, that cannula. This is interesting to see and to understand. The healthy cartilage is like you're taking a boiled egg, you take the scale off, and you put that white egg into the water and you take it out. It's smooth, it's soft, it's perfect. And it's white like a purple. This is degenerative cartilage. And that's a great one change because we call that fat degeneration, not because of the fat, just because of the color that imitates the fat. And this is the first biological change of the cartilage. And you can have a perfectly normal x-ray with no narrowing of the cartilage whatsoever, no mechanical change with that quality. It's going to give you the same symptoms. Perfect x-ray can't walk. This is a mattress suturing. When we don't go around, we go in a center, and you can also see the changings, and you can see a bubble formation and start of fissuring of the cartilage here. Again, very nice presentation, where because of the labrum tear, there is a distinct difference between normal cartilage on the femoral head and a part of acetabulum and damaged cartilage. Then we can have a different ways of how to treat it when we treat without doing anything except kissing it better, because the labrum is first of all very small, hypertrophic. This instrument is 2 millimeters. So if I'm trying to do something with my instruments to it, I'm just going to destroy it. So you're trying to preserve the nature as much as possible. And secondly, if you're having a damage in a cartilage without having a damaged labrum, you can try to do something else. You can try to glue it. So we're using a fiber glue where they pinched it from the cardiothoracic surgeons, and we're gluing the carpet back to the concrete. This is how it looks like on a movie. Down there is a labrum tear between cartilage and the labrum itself. This instrument is 4 millimeter diameter. Now this is a 3.5 millimeter diameter. I'm drilling the hole at the back of the labrum into acetabulum, carefully watching that I'm not perforating into the joint, putting the anchor inside, and throwing the stitch around the labrum to stabilize it. My job is to stabilize the labrum, the same thing like a knee surgeon stabilizing meniscus, until nature heals it. Yes. But that was a long time ago. We haven't improved the instrumentation since then. They are much smaller. But this is a suturing technique that I designed, which gives me certain stability and possibility to undo it if I want to, because most of the arthroscopic suturing is designed that you have a sliding knot, it's there, it's done. And if you make any balls up, you wanted to take it off without making any extra expenses. So that's why I try to do a little bit more complicated, but works. So this is what is happening. So if we're talking about the CAM, we have MRI, we know where the damage is, we can visualize it in a periphery, we can mark it, and the convexity can be changed into concavity. So the question is now, where's the pendulum today? What we're doing and how we're doing it, all of those things now. And answer to that, we saw that previously, this slide about layer diagnosis. And thanks to Hall Martin, we all trying everybody in the world to use the same principle, that you start and you layer it, the pelvis, into the areas, and you try to exclude the problems one from the other. So if we start with the osteochondral layer, we're talking about static overloads, dynamic impingement, and dynamic instability. On an inert layer, we're talking about soft tissue, labrum, ligamentum teres, and capsule, going out onto the periphery, and then going down to the deeper layer, which are nerves and spine. So osteochondral layer. Acetabular dysplasia, it is described that 63% of all of those patients are having some abnormalities, and they're going to have a problem in the future. And we know that 50% of dysplastic hip have a 50%, all of them, they have a 50% chances to have a hip replacement by age of 50. And in Europe, they use prevention. There is no child that is born that doesn't have to have an ultrasound on a certain time to prevent dysplasia, because you can treat it in the childhood, you can treat it in a teenage, you don't have to wait to become adult and land up with a hip replacement. Now, in my experience, it's about 50% chance of success to have patient who had a hip dysplasia be treated with a arthroscopy. But all of those patients are telling them, listen, I'm not treating a cause of the problem, because that's your bad skeleton. I'm treating your symptoms. So this is what I presented the study in 2015, and that was a follow-up of a minimum 3 years. If we know cam and pincer, we touched that already, so we're not going to go deeper into that. Also related to the protrusio, completely opposite to dysplasia, there are conditions that can be treated arthroscopically, but it has to be very careful analysis of the patient before, because you don't want to be one who's going to make the patient worse. And then we're talking about instability, and those are the certain slides that happens in that particular cases that we discuss it when you have an impaction or you have a pieces of cartilage sitting around on a femoral head. This is called the apple bite, Pipkin type of fracture. When you have like apple bite of the femoral head, you can have pieces of cartilage being removed purely because of instability and because of subluxation per se. When I do operations, I know what I'm expecting, and then I'm looking into what's happening during the surgery. Now, watch here. Look at how this is open. I almost could dislocate that here. And that was just the forearm, not even body weight. So that automatically, big red flag, this patient is unstable, there is a presence of instability, be careful. And that same patient has a huge amount of bruising in that labrum because of that intra-articular motions which are related to instability. Then I tried to, and I did a fixation, as you can see in the bottom there is an anchor. It looks fine until I flex the leg. So look at what happens. That is a patient in extension, and I'm flexing the leg. At 60 degrees, 50% of subluxation posteriorly. She doesn't even know. She has a pain here and there, but that's the problem. So it's not all about musculoskeletal. You have to look into the genetical, into the collagen, fibrogen, capsule, and so on and so forth. Then we're coming to the next layer, which also interpolates the first one into the second, being a capsular instability, but other structures which are, from soft tissue point of view, important, like a ligament, labrum tear, and ligament instability. So you can have instability because you are contortionist, or you can have instability because you want to be contortionist and you made yourself contortionist. Two completely different things. So that bloke down there, that's from Australia, that's from John, and that guy was stiff as a brick, and he made himself to do that. Different people. So we're looking into labrum, as we saw it before. We're looking into the ligamentum teres injury, and that's, by the way, his, and we're looking into that. So when we have adjacent injuries, we can fix them. So we can do labrum repair, as you could see, and we can do even labrum reconstruction. So we can take allograft or tender, some other tendons out of the body, and we can repair it, labrum which is completely missed. Same like knee surgeons doing with ACL, PCL, and so on and so forth. Or we can use a graft and repair ligamentum teres. And that's where this traction MRI comes very useful, because it helps us, besides analyzing the cartilage, also what's happening with a ligamentum teres in a certain motions. We can have a completely degenerative missing, or we can have a chronic tears, as you could see on that picture. And then, if it's necessary, and in my career it happens only twice, other two patients, they immigrated, so it was done somewhere else, so there was 4 cases that I was planning to do. So it's a very rare, but there is a conditions when you want to do, same as a ACL or PCL in a knee, you want to do reconstruction of the ligamentum teres, because it does give some stability, especially in a seriously unstable conditions of hypermobility and so forth. And then you can have instability not only in the different motions, in internal and external rotation. So look at what happens here. When the patient goes into the internal rotation, that's a ligamentum teres that is pissed off. You can see how it's swollen. Why? Because it hits into the edge posteriorly. It hits inside of the joint, in a fossa. In that area, the contact is happening. So you can have a deep impingement, and if you don't look for it, you're not going to know for it. Same way with the external rotation. You see how it gets brushed off edge of the acetabular fossa, or fovea acetabulae. Coming back to that slide that you see, Baton test, dialing test, you must make a diagnosis of hypermobility, because the consequences of not doing it can be quite significant. What do we do for those things? We do either physical plication when we're using a stitch, or we're using a thermal instruments when we're actually shrinking the capsule. So we're making a capsule tighter thermally, and that's called a thermal capsulorrhaphy. We're not killing the proteins. The temperature is about 43 degrees, so you're shrinking the cells, but without actually destroying the proteins. Then we're coming to the third layer, excuse me. And you have a front, back, lateral, in all around. Talking about SIJ, sometimes people come and say, okay, this patient has a hip problem, and you try to go in investigation and actually doesn't. So if somebody did a surgery on him, he would be wasted. And making a proper diagnosis, he won the yellow shirt. So same way, we have an athletic pubalgia, which you can see there in the front on the symphysis, which see those white signal, which is the increased signal of irritation of the symphysis bone. And those conditions, most of the time, don't need a surgery, needs a rehabilitation, needs a proper training program. Then we come into the medial side, anteromedial side, when we have a psoas. So the internal snapping hip. Patient comes and says, doc, my hip clicks. And you do the certain movements, and you can hear it. And we always say, internal snapping hip, you can see it on the other side of the room. internal snapping hip, you can hear it on the other side of the room. External snapping hip, you can see it, and you will see just now. So what is happening is you can have problem with the psoas, and sometimes it needs to be released. Very rarely, but can be released. And that's also arthroscopical procedure when you find a tendon and you cut it. Most commonly, that problem is related to arthroplasty because you are putting something in area of the psoas tendon. You're producing a scarring, you're producing something that is going to irritate the psoas nerve, psoas tendon, and it could be of significance for the patient. So you can release it at the lesser trochanter. There's 3 places that can be released, and if you release on a psoas tendon at the origin, you're going to have basically no psoas function. If you're releasing in the middle, where is a tendon muscular junction, you're going to lose only about 40% of that function. And if you release on top of that, you're going to lose less than 20% of the function. So there's anatomically different places where it can be psoas tendon released, and depends on, again, examination that I'm making decision where I'm going to release it. This is something fascinating. Sometimes person can have 3 psoas tendons. And it happens to everybody who does the surgery that you release it, and patient comes back to you 6 weeks later and says, Doc, I have the same problem. You take an MRI and it's another tendon there. Happened to me. And once happened that I found 3. So that's the first and last. I've never seen it. And my colleague says also they've never seen it. But anyway, it's interesting. So now we're talking about that sports hernia, which changed the name to inguinal disruption. What we're talking about is something is happening in that area around the hip, which can be examined and have a positive findings on examination. But essentially, what is the cause of it? Back to that Bermuda Triangle. And the problem is that usually sports male patients, and he says, Doc, it's only when I do something. And he says, okay, fine, have a test. We're testing it, fine. Rehabilitation, fine. No sports, okay. I'm great, fine. He goes back on the field, exactly the same problem. So you can catch it only in activities, and that's what makes the problem. And the communication with clubs is very important because of expectations. So what do we have anatomically? You have a rectus, you have adductors, you have a symphysis, you have an inguinal canal, an inguinal ligament, and all of that is pointing into the one central point. And anatomically, that's what you have. You have triangulation, rectus, oblique, adductors. And very often the patient's going to have a presentation of an adductor spasm because of the abdominal wall problem. Because that connection, that footprint, is in continuation. So all the physical tension from the abdominal wall gets transferred into the adductor longus. And then on top of that, what do we have? 1.5 centimeter to the hooker left, and you're in a hip. So you can have a presentation of the hip and combination of Daryl. Back to the statement that I told you before. Very, very important. Think out of the box. It's not everything only one condition. It could be a combination of it. So there's many articles showing that groin pain can be in combination of hip and the groin per se. I have to rush a little bit. So our standing is, and I work with Mark Ferguson, who is our sports physician for many, many years, and we're saying that we actually have to have open box thinking. And we have to look into the both concepts and thinking it that way. Is it connected? I personally think that it is. Some of my colleagues from Ireland and from Belgium think that it's not, but I think it is. Literature shows that we have plenty of combinations where they're talking about adductor strain, labrum tear, rectus tear as a sports hip triad described. Then we have from the Australia something that is called in Aussie rules in rugby. This is just, what do we say? This is me, myself and Mark Ferguson when we do the study in 2010. 50% have a patient longer than 6 months before they're seeking the help. It's a very, very important. And most importantly, which is not mentioned here, 25% in pediatrics. We have here 6%, 25% in pediatrics. So you can see it there. So what are we trying to do? We're trying to prevent it, we're trying to diagnose it, we're trying to make sure that it doesn't happen. In 2015, with all those confusion, because it's a Bermuda Triangle, we had a meeting in Doha when the decision was made, this is going to be. The groin pain is going to be classified in 4 different groups, and this is it. We're going to adductor, inguinal, iliopsoas, pubic. Boom, boom, boom. 4 spots. And everything else goes into others. But it's still, in my mind, a syndrome. You can have a combination of all above. So, surgically or conservatively? Inguinal disruption or sports hernia or Gilmore's groin, there's millions of names in the literature. You can have an orthopedic surgeon, you can have urologist, general surgeon. In my opinion, that everything starts with the prevention and rehabilitation. So we start a screening initiative when we actually went into the schools, pick up the 13-year-old kids, and just randomly examine them for the hip and pelvis problem. Guess what? 17% positive. They don't even know about it. So what we do, we flag them and see them, follow them. For the next 5 years, 4 of them out of 27, 4 of them already had a surgery. So not everybody is for surgery, but they can have problems later. So what we try to do, we try to close that circle with rehabilitation of quadratus lumboris, posterior aspect, adductors, the whole tooth around the pelvis, which is not my speciality, to change that to the normal position. And we do that by improving all of those, strength and all other things which my physios and bios do, including the strength in the motion, in repetition. Coming back to the functional assessment that give us objective analysis and follow-up. If it's a soft tissue problem, that's what we do. You can see this is a sports hernia. It's not hernia like an inguinal or femoral. It's actually a weakening of the fascia that is related to the external and internal oblique muscle. And when you squeeze, when you sneeze, you're going to cause that muscle to protrude through that fascia, and it's going to piss off the nerve that runs in the front, and it's going to cause the pain. And it's constant with training and cause the weakness. So what do? We stitch that. We try to do anatomical repair. So you can see how that gap is actually closing. What is important to find out, is it that consequence of micromotion of the femur, pelvis, the whole thing? And if it is, combined surgery applies. So this is between me and Mark Ferguson that we did, and we had 120 combined surgeries. The problem is what to do when you're not sure. That is a question of clinical examination and everything else. Coming back to the lateral side, we can have abductor problem, and it's not everything bursitis. It could be actually a defect, which has to be surgically treated. Going to the external snapping hip, you can see it from the far. Oh, sorry. If you look carefully, you will see how it's clicking, and this lady had a hip replacement for the lateral approach, and she has a hip that jumps. And this is purely related to snapping of the ITB tendon over the greater trochanter, and arthroscopically, the tendon on the side of the hip can be released. And then we're coming to the back of the body. We saw that before. We're talking about the hamstrings, external rotators, and something which is called the deep gluteal syndrome, which could involve different muscles and different nerves specifically. And fascinating studies that Hall Martin does, looking into the correlation between those structures and the sciatic nerve dynamically. An amount of motion that happens is amazing. Hamstrings can be treated with open surgery. and can be treated arthroscopically. That is the issue. We talk about piriformis syndrome. This is a historical thing from many, many years ago. There are variations of it. But now that suddenly becomes so important in combination with the IFI stuff. So it's not anymore isolated piriformis because that is relationship nerve with the piriformis. No, you have to look at it a little bit more open. So differential diagnosis is about it. What we're looking for? We're looking for the pudendal nerve. We're looking for the, is it hamstrings or is it IFI? We're looking into that other stuff related to the piriformis and the space at the back of the hip. In some sports, pudendal nerve can be involved. When I have something like that, I send it to somebody who knows more about it than me, and we have a gentleman who he was trained in Durban for that. He went to work with Hal Martin, and this is a fascinating study when he's using a nerve conductions and he's trying to see what's happening in the nerve during the certain motions, and the fact that nerve doesn't just slide, it rotates at the same time as it's sliding when we're doing a certain motions. An amount of strength, the lengthening of the nerve is enormous, 2 to 5 centimeters from standing to sitting. We mustn't forget the spine. It's very important to think one level above. If you're still confused, go to the examination of the spine and see if any of the dermatomes are involved in the symptoms. So where's the pendulum now? We do have a hip preservation society. We're expanding it to the further out from hip arthroscopy, as you could see. It's much more bigger field. We're involving the open surgeons. We're looking into the preservation. We're looking into the biology. We're looking into rehabilitation. So we have 4 subgroups that are working on different researches. This is just quick press of the button. Just in 2018, we had over 180,000 articles. Where's the future? Future is in presence of science, robotic testing, and trying to understand the concept of biology and motion at the same time. And then we're using a different ways how to understand motion and influence of the motion to the musculoskeletal system, and try to adjust it one to another and improve our preservation. We're looking into the different studies around the world. This is from Geneva. When we're looking into the professional ballets, where during the motions are happening more contact on a control surface. And based on that, we can plan our intervention better. Thank you very much.
That was amazing. Thank you, man. Appreciate it. That was very good for you.
Thank you very much.
When you were okay. And thank you very much. Cookies and stuff. Thank you. Really, that was awesome. Ladies and gentlemen, I think the webcast might be finished now. We've got half an hour for a tea break. For the people in the auditorium, Mr. Mike De Silva has sent you via your email your barcode. So take a screenshot of it and then get it ready on your gallery. And when you come in, when you come before lunch, you scan out, and then after lunch, scan in. Just before the AGM, scan in, and anytime you leave the AGM, scan out, and at the end of the AGM, scan out. So obviously, we'd like you to be at the AGM until the end. All right. I think that was wonderful. Dr. Chuck, that was amazing. We'd like to see more of you and hear more from you. The only problem is patients have to wait about 6 months to see you. And that's how good this gentleman is and how much time he has put into research He cares for every patient he sees, and he's operated on family of mine, he's operated on my patients, and it's great to have you part of the team. Thank you.